We are back, DNA. Kate Wilson here with another episode of All Access DNA. I missed working on the podcast while on hiatus, and I'm excited for the updates we will be releasing over the next few months. Make sure you follow us on Instagram and subscribe to our feed in your favorite podcast player so you don't miss anything. In today's episode, we are talking to Natalie Richeimer, she, her, about pre-implantation genetic testing, or PGT. Natalie is a board-certified genetic counselor at JScreen with clinical experience in adult, pediatric, and reproductive genetic counseling. She is passionate about reproductive health education and community engagement. Let's get started. Hi, Natalie Richeimer, and welcome to the show.
Thank you so much for having me, Kate.
I'm so excited to talk to you today, in particular because this is an area that I'm not as familiar with in genetics. So it's definitely a learning opportunity for me and in addition to our listeners as well. So you work in the area of pre-implantation genetic testing, or PGT. And so I was hoping you'd tell us more about what is pre-implantation genetic testing.
So before we kind of talk about pre-implantation genetic testing, it's a test that's part of a process with something called IVF, or in vitro fertilization. So if it's okay, I'm going to take a step back and talk about what IVF is and why somebody might be doing IVF to begin with. So IVF in vitro fertilization is a process where we can essentially take sperm from a sperm source, egg from an egg source out of the body, put them together in a lab, and create an embryo. An embryo will eventually turn into a fetus, which will hopefully become, a live birth child at some point. But that process is what we use to do that IVF process. And people may be doing IVF for a lot of different reasons. They may be doing that because they're in a same-sex relationship. They may be doing that because of a cancer diagnosis. They may be doing that because of infertility. There's a multitude of reasons why someone might be doing that. And one of them includes for the ability to do genetic testing. And so when we talk about what pre-implantation genetic testing is, it's essentially a test that's done after we've removed egg and sperm, put them together to create that embryo. We let the embryo grow to a certain stage of life, usually about 5 or 6 days, and it'll have a certain amount of cell or little building blocks. Cells are little building blocks. And at that point, there should be different areas in the embryo. So some of them will become the areas that will form the baby eventually, the fetus. And some will be an area that will form the placenta. And that area is what we call the trophectoderm. I'm being very specific because what we can do with pre-implantation genetic testing is we can remove or pluck a few of the cells from that area. Typically, we pluck them from the trophectoderm, and we can test those cells before pre-implantation, before we put that embryo back into the person who's carrying it into that uterus. And while we're doing that testing, we freeze the embryo. And so the person who's doing PGT will usually do it for a multitude of reasons. Some of that can be because they're carriers of a genetic disorder. And some of that can be because they want to screen for common chromosome conditions like Down syndrome, trisomy 21, 13, 18, or other chromosomal conditions. And sometimes it can just be because of an inherited chromosomal or structural chromosomal disorder as well.
Okay, so you're saying that typically PGT is a part of IVF. So generally somebody that would be undergoing pre-implantation testing is somebody who's also undergoing IVF as well.
Yeah. And again, not everyone who does IVF does PGT, but you must do IVF to have done PGT.
I see. Okay. And so with IVF, as you stated, there can be numerous reasons why a person or a couple may choose to pursue IVF, or that may be the option for them to be able to start a family. So if not everyone who has IVF has PGT, why would somebody add, I guess, that PGT part into their IVF journey?
So it's a really great question. And when we talk about PGT, there's 3 types of PGT that we're dealing with typically. There is another one, but I'm not going to go into it because it's not as standard as the other 3. One is PGT-A, A for aneuploidy. One is PGT-M, M for monogenic. And one is PGT-SR for structural. So typically people who are doing PGT-A are people who want to screen the embryo for common chromosomal differences. And the reason for that is we know that most losses in the first trimester are due to chromosomal differences that make the embryo non-viable. And so for some people, they want to screen that embryo because they want to increase their chances of success for a live birth pregnancy. And so that's done. I would say it's not standard, but it's more common more and more as the years have gone on to add in PGTA. PGTM and PGTS are a little bit different. So PGTM, we're looking for a specific genetic condition that someone and their partner or the person who they're having the pregnancy with carry. So for example, let's say something like cystic fibrosis, which is a recessive condition. It may be something that just one person in the group carries. So like something like BRCA1 or BRCA, we're looking for a specific gene and a specific gene change that would be causing this condition. That's what PGTM is. PGTSR is a little bit different. It's somebody who has like a chromosomal rearrangement, the parent or the person who's donating the egg or sperm. And so we're screening the embryo to make sure that that structural rearrangement isn't passed on, or we can kind of look more closely for that, if that makes sense. So multitude of reasons why someone's doing that PGT, but overarchingly, it's for somebody to hopefully have the best chance at a successful live birth and pregnancy, and hopefully have a child that doesn't necessarily have a condition that the parents may carry or the parents themselves may have.
And so you mentioned those three different types. Do people typically have one versus the other, or do some people undergo all three?
I don't think most people, I mean, listen, I can't say I haven't done all of the IVF in the world. Typically people I'm meeting, most people I've met through the fertility process have done PGTA, that first one. That's just a basic screen to check that all the chromosomes are there and in the right number. A lot of people will opt to do that one. PGTM means that you have a specific genetic condition. It's, I would say, less common. So like I said, example like BRCA1 or 2, so the parent is a carrier, or cystic fibrosis, the people who are contributing egg and sperm are carriers. Those are things that there would be a specific reason less common. SR also less common. So it's somebody who's coming in with a known genetic reason, typically. Sometimes it's not that, for doing IVF.
And I was going to say, with one of the PGT, we had a guest a few episodes back, Matt Hay, who had NF2. And so he talked about having IVF and PGT with his children.
Yeah. And I think like it's so powerful. Like I've spoken to, a colleague of mine who he works at JScreen. He's the CEO, and he and his wife unfortunately had a child that passed from Tay-Sachs, and they did IVF for a subsequent child. And he had said it felt so powerful to him to be able to wipe that from his lineage, right? To be able to help make sure that, he was going to be able to have children that could live a happy, healthy life in the future. So I think it can feel really empowering for patients to have this option.
How accurate is the PGT? Because like you were saying, it's happening when it's like an embryo, right? So there's some cells that may become this or some cells that may become that. So is there any chance that you would test one of those cells and maybe it's not really representing the full embryo?
That's a really great question. And no one likes me when I say the answer to this. So I'm going to be honest, but I am going to be honest. PGT is screening, meaning we haven't tested the whole embryo. We've tested a few cells. And if anyone's ever played a game of statistics, if I put a bunch of different color balls in a bag, you could just pick out all yellow balls, even though they're green, purple, and pink. We hope that those are representative of the entire embryo, but we're talking about an embryo that's very teeny tiny and small. And we know that once, a baby is born, we're talking about millions, billions, trillions of cells. So the chances are, like I said, if we find everything looks good, chances are that it is representative. And that's what we're hoping, of the entire embryo. But again, we're testing the trophectoderm, which will become placenta. So that's not baby. And sometimes what can happen is the trophectoderm may have different cells than baby. That happens. I've seen that in prenatal a bunch, where, we thought that the placenta had one type of cells and the baby didn't. So I would say it is a really great screening test, but it is not diagnostic, meaning if somebody is very interested in knowing, does my baby indeed have condition X or condition Y, I would always recommend diagnostic testing, either when baby is born or when the pregnancy is happening, either, via amnio or CVS, when we can get a bigger sample selection. So I wouldn't say it's not that it's not accurate. You're getting accurate information from those 5 cells, but is that representative of the whole fetus? Hopefully, but we can't with certainty say that. And so I think that is something that's important. There's another concept. So we've talked about confined placental mosaicism, meaning the cells of the placenta or that trovector that will turn into placenta are different than what the baby will become. There's also just general mosaicism where we can see throughout the whole body of a person that they have different types of cells. So some of them may have an extra chromosome and some of them may not. And depending on how much of the cells with the mutation or extra missing chromosome are there will depend on the severity in the child. And I've seen just for facts, I've seen like grown adults who have been mosaic for certain disorders who totally don't show any signs or symptoms because they're very, very low level.
So let me ask you this too. If somebody were to say, what's the percentage chance that this is an accurate result or this is truly reflective of what's happening in the baby? Do you ever put numbers on that? Or is it sort of?
I don't. I'm sure there have been numerous studies and this and that. But again, what we will always say to people is this is a screening result. We recommend that let me pause. This is a screening result. We recommend that you get diagnostic testing done if you are interested later on in pregnancy. Meaning in genetics, there's never ever saying there's a 0% chance or 100% chance. I would also say it really depends on what we're screening for, right? If it's PGTM, that's very different than if we're screening for whole chromosome aneuploidy. And so I don't give a specific percentage result to patients, but I do think chromosomes are a little different than genes. And that's like a whole conversation in itself. But I do think we can reduce risk for specific conditions in a good way. The only way we have at this point with something like PGT. So I never would want a patient to think, well, oh my gosh, I'm spending all this money and this time and it's not even reducing my risk. No, it's significantly reducing your risk. It's just we haven't completely reduced it. And there's no way to ever completely reduce risk, but that next step is really important.
Yeah, I think that's one of the misconceptions with any genetic testing, whether it's PGT, diagnostic whole genome, things like that. There's never a result that you will get that says, okay, 0% chance of anything. Everything is always totally A-okay.
Correct. And I think that's something that people really don't like to hear. And I used to say, when I worked in prenatal, I would say I can't ever guarantee anyone a healthy child, even if all of your tests come back normal. I just can't, because I don't know if your child will develop cancer later on in life. I don't know if your child will develop, some sort of muscular issue later. We can't screen for everything. That's just the limitations of the field of medicine in general. I can hopefully give you a reduced risk, but I can't guarantee anything. And I think that's very important when people go in to this space. There's a lot of high emotions. It's very charged. And to be realistic of I can't guarantee anything. And you can't guarantee even you go through this space, I can't guarantee you're going to get an embryo with all the things checked off that you want.
Right. And it's sort of I can't guarantee that you as the person sitting across from me are not going to encounter something later. I don't know. Right.
Yeah.
And so it's not necessarily. It can give us a lot of information. It could change the chances that something is happening or will happen, but it's never going to tell us the complete, full answer.
Absolutely.
Is it challenging when you work with patients who are coming in for something like a PGTM, right, where it's a gene test and you can't necessarily predict the severity of a condition? Because we know that some conditions, right? And I think about NF and some of the other ones that have sort of variable expressivity, reduced penetrance, or things like that. Is that hard to discuss with patients?
It's hard when we're dealing with lower number embryos, right? So I always say, people don't just come in with one problem. Typically, it's a bunch. So they're coming in because they're PRCA1 positive and they want to do PGTA. And this is, a female who's in her later 40s. In the game of unlimited eggs and sperm, right, we should be able to get 50% without the mutation and 50% with, and, a certain number who are chromosomally chromosomally typical, but that's not the reality we're working with. And when somebody has been retrieving, a lower number of eggs and they get one that's chromosomally typical, but it's still, like you said, is a carrier for a specific condition. And now we have to go into the weeds of, well, how severe, like you're saying. I've seen situations where people have only gotten a chromosomally normal embryo that was a BRCA1 or 2 carrier. And then they have to think about, well, this is my only embryo, right? And maybe I should put in a male BRCA1 embryo because it's less severe, on male versus female embryo. So it is tricky, and it does get into the weeds with that a lot. I mean, most patients are coming in and hoping that they're going to get that embryo, like I said, with all the check marks, right? Like chromosomally typical and free of genetic condition. And you are right, Kate, is very, we come to a place where if we don't get all those things, then we have to think about what we have and what that looks like for the child. And it's tricky. I'm not going to lie. It's very, very tricky.
Yeah. I think some people think that now that we have these types of technologies or capabilities, that means we know everything, and we're just not there yet. And the other thing I would add is that it sounds like this is why it's very helpful to have someone like yourself, and I imagine many of the physicians as well that work in these fertility or PGT centers have these types of discussions from the get-go with the patient. So is that typically like kind of what somebody in your role or a reproductive genetic counselor would do in these that works with like IVF clinics, is have these conversations?
It all depends. I mean, we get people at different stages of the journey. So I've worked with a lot of people who are preconceptions and they just done carrier screening and they want to kind of know, like, should I be doing this next level IVF with PGT or without? So I do a lot of those discussions, especially with things that are like X-linked. It's a bigger conversation. And I would say we've definitely talked about it. I mean, I'm not going to go into this because it could be a whole podcast in itself, but like there's a lot of conversation about mosaics. I know you're smiling because that's like a really hot button thing. Listen, IVF in this country, I want to say, is unaffordable for most people. And there's not typically insurance coverage. So some people, they've got one shot and all they get are embryos that are not the typical embryos they wanted. And so those are conversations of, listen, I want to become a parent and all I have is this mosaic embryo. Like, what do I do? And what does this look like? And what are the chances that this child, will be live born? And what are the chances of, health concerns? And that is where a genetic counselor can be really, really helpful in going through and stratifying the risk and explaining kind of what we can potentially see with an embryo like this. And it's also like advising the doctor, right? Like our doctors are amazing people, but they are strapped with time and they don't necessarily have the time to go into the nuances of every single genetic condition with their patient. And we can be helpful in advising them and working as part of a care team.
One of the things that I wanted to ask is, you had mentioned that PGT involves the removing of a cell or maybe multiple from, and I'm going to, the trophactoderm. See, this is, again, guys, you could tell how old I was when I came through grad school because none of this was like a thing. So when they take those cells, is there a risk associated with the PGT? Like, how does that potentially impact the embryo?
So that's a great question. I mean, whenever we biopsy an embryo, there's risk. Whenever we freeze and unfreeze, there's risk that it can damage the embryo and cause it to be non-viable. They've gotten really, really good at it. And I would say like the technology is continuing to improve. I think there becomes a discussion and it's always like this is medicine, but this as well. Like, and I am not an embryologist. So if you're an embryologist listening, you will speak to this better from what I've understood from embryologists. Like some embryos are a little more fragile than others just based on the genetic material that's been, handed over to them and may not survive a freeze. So if someone's doing PGT, they're going to have to freeze their embryos. They are not transferred right away. They are frozen because we have to wait for those results to come back. And that takes time. Some embryos can't handle that type of a freeze. They're a little more delicate, shall we say, and they may not be able to handle a biopsy. So we may want, if somebody, like I said, limited resources, limited time, we may want to do a fresh transfer. Fresh transfer means we take out those embryos from the lab as soon as they're ready and put them right back into that uterus. It just depends on what we're dealing with, but there is always a risk. I think it's important to talk to your care team of, do we think based on my particular circumstances, are my embryos or what we perceive to be the embryos that I will make, are they going to be strong enough to handle biopsy and freeze? And if the answer is no, and you're spending that kind of money, maybe we don't do that and we test in pregnancy. But it's really, really important if you're spending that amount of money and the amount of time to have that conversation. If the answer is no, then maybe this isn't the right path for you. And I think that's the most important thing people should take away from our conversation, Kate, is that there's no one size fits all in genetics. Everything is very individual, and you need to figure out what works for you and your circumstances the best.
And you had mentioned that on doing PGT, they will freeze the embryos because it takes time to get the results. How long does it take to get the results back so that somebody can find out?
That's going to be lab dependent.
Okay.
I would say usually like about a month to like 3 weeks from what I remember, but I'm sure there are different labs that can do it faster, slower, or something in between. But it's not 24 hours. It's a substantial amount of time.
Right. And one thing that you had mentioned a couple of times, and I think we definitely need to talk about is the cost and what's involved. Because as you said, in the United States, we have mostly like private insurance, private payers. We have some federally funded as well, but typically IVF just in general is not something that's widely covered here in the US.
Yeah. And I think for those listeners who aren't in America, most people, like you said, are getting health care through their employer or their private plans. And there's typically not mandated IVF coverage. And so some people get lucky and they're lucky enough to have their employer cover that. Most people don't. So most people are paying out of pocket. And I mean, prices can vary wildly based on a state, right? And even within the state where, so, some clinics, it might be 10,000 and some might be 30,000. And everything is like an add-on service, like a la carte. So, there's the price of the IVF and then there's the price of the medication. And the medication can be, again, like $5,000, $6,000 without any insurance coverage because insurance doesn't cover that. Then you have things like PGT, which, can be really pricey because sometimes they'll, do a package deal where they'll test 10 embryos. And if someone makes a lot of embryos, they may have to pay more. It can be thousands of like $5,000, $6,000 on top of that. And they're all separate. Sometimes it comes down to money for people where it's like, I would love to do PGT and have, a less reduced chance of certain conditions, but I can't afford it on top of the IVF, which I can't afford. I want people to understand that this isn't like, a few $100s. This is tens of thousands of dollars, and that's if it works. And so when people are doing the IVF process, there's typically a lot of workup stuff that they'll have to do first, testing just to see, what we're dealing with. That's money. Then you get to the process of the IVF retrieval, which is where we get the body of the person with the eggs ready. To, produce a lot of eggs, and we retrieve them within the surgery. That's, like I said, tens of thousands of dollars. We're talking about like $10,000, $20,000 for that. And then again, putting sperm with egg, that's going to cost money. The PGT testing is going to cost money. And then we're also talking about after that, doing an embryo transfer, which is going to be thousands of dollars as well, and requiring new different types of medications as well. So it is a lot of money. And unfortunately, for a lot of people, it doesn't work the first time. So they may not get the right number of eggs. They may not produce enough embryos. The embryos they may produce may just not have, like we said, the genetics to make it a viable transfer. They may do a transfer of a completely healthy embryo and it's an unsuccessful transfer. There's just so many kind of pieces to that. And I think that's really, really important for people to realize when like the general population will just say, oh, just do IVF. That's like saying just win the lottery. We'd all love to win the lottery, but it's not accessible to a lot of people in this country, unfortunately.
Right. I think it does get tossed around a lot as like, oh, here's an option. But for how many people is it legitimately an option for?
Yeah.
Does it increase just the overall chance of becoming pregnant? Because I will say that my experience with friends and family has been people who have undergone, because they've either had some pregnancy losses of unknown cause, or they've just not been able to get pregnant after some years of trying. And so they will undergo like IVF and maybe the PGT and aneuploidy in the hopes it will increase their chance of becoming pregnant.
And we know statistically it does increase the chances of pregnancy. Obviously, there's other factors that are involved. It depends on why we're here. And, it's not just the embryo, it's also the uterine environment that will, make a successful pregnancy and dealing with those kind of things. PGT testing and IVF does increase your chances of a live birth pregnancy pretty substantially. And that's why some people will, again, it's not just the PGT itself, it's the IVF and everything else.
Right.
And, us having a little bit more control over hopefully the uterine environment and the hormones, et cetera, it does substantially increase the risk. And increase the results of hopefully successful pregnancy, which is why people are willing to do it. There's a lot, like I said, a lot of data out there about PGTA that is tricky because there are people who are huge proponents of it, and you will find people on the opposite end who are incredibly opposed to PGTA for multiple reasons, but from a genetics perspective, because there's a feeling that we're discarding really healthy, viable embryos because this test isn't all the things that we think it is.
Well, and actually that leads me to the next question, which was like, what are some of the ethical considerations, working in PGT? So when you talked about one there, and there's also questions of, what to do with the embryos that aren't implanted. Should we only have embryos that have these types of things? Should we still implant them, even if that's what we originally intended not to do? So I'm curious if you can go over, and again, each of these could probably be a standalone episode.
100%.
But what are some of the ethical concerns around PGT?
You're asking the hard questions, Kate. There's a lot of ethical feelings with genetic testing in general. So just throwing that out there, there's always this feeling of, from some people, this fine line that we walk as genetic counselors of reducing risk and eugenics. And I will say that, are we trying to create a world that is free of disability? And there are people in the disability community that feel very strongly often against certain types of testing. And I want to hold space for that because I understand that people with disabilities make our society incredible, and they are hugely important in the fabric of our society. So there's always that feeling with genetic testing, especially in the reproductive space. Are we trying to rid people of disabilities? That's a huge ethical concern. I think that is interesting. I think the flip side is also interesting of thinking about what is ethically okay. Is it okay to put in an embryo knowingly that is going to be at an increased risk for certain cancers, let's say, or diseases? And I think it becomes a really big conversation. I think with, like I said, mosaic embryos could be a whole discussion in itself, but is there a problem putting an embryo that could have pretty significant health challenges, especially are we, being responsible in doing that? I don't have answers to these things. I think it is really tricky. And especially in the world of reproductive genetics, it's very gray. I do know that, certain countries put a lot of very heavy limits on the conditions that they can do genetic testing for. I know that certain countries, sex selection is a big part of why people will want to do IVF because they want to have a specific sex of a child. And so certain countries have actually banned that, and the United States hasn't, but certain people will come to this country because they want to have, a female or male embryo implanted. That's something that's really important to some people. I think there's a lot of gray area. I think it's complicated. And I think that's why genetic counselors are so important. I think genetics always plays a really hard role between patient autonomy and, like you said, ethical concerns. But I will say, having gone through IVF myself, for all three of my boys, the process is horrible. It is a horrible, horrible thing. And most patients aren't coming from a place of eugenics. They genuinely just want to have a child. And so for them, doing this is to make sure that they have their best bet or their best chance of having a child. And so for me, I don't place judgment on my patients. That's a big thing, I believe. I'm not them. I don't walk home with their circumstances at the end of the day. They're the only one that does. But I do think that there is a fair amount of regulation in other countries that isn't here. And that brings to question whether that's a good thing or a bad thing. I don't know the answer, but it's something to think about for sure.
And I appreciate you sharing your own story. Do you think that has helped you maybe relate to the patients, or like you said, to just say, I'm not in their circumstances? I walked the road they're walking, but it was a different road for me. It was a different circumstance or different situation.
It allows me to have a lot of empathy. Again, not every patient who's done IVF with PGT that comes before me or is trying to do that is me. They're not, none of them are going to be me. There's only one me. Like, I'm not in a same-sex relationship, so I haven't had to hire a surrogate, to carry my child. That's a lot. I haven't, had a lot of other issues that other patients may have had. So like you said, I can't relate to everything, but I know the strong desire to have a child, and unfortunately having to do IVF to do that. I can't speak for everyone, but my feeling always is like, most people don't want to have to do IVF to have a child. It's the only way that they'll be able to have a child. And it's not something that's easy. And for me, understanding that and also understanding the anxiety that comes with hopefully a successful IVF pregnancy is there too. I had said when I had my last child, my friend who was an IVF friend of mine had said, like, you had the baby, now you can finally exhale. Like, you've been holding your breath for 9 months. And I'm like, yeah, no, that's what it is, because IVF is a process of very high highs and very low lows. And a pregnancy is you're almost at the finish line. You can see your dream, and like, you can't exhale for 9 months. It's not that. So I see that in my patients. And so for somebody who hasn't maybe dealt with an IVF patient before, they may not understand, the stress or the anxiety that comes with that. And they may not counsel, but understand that their pregnancies are different. Their emotions are different, and hold space for that, and be patient with your patients.
Mm-hmm. I like that. Be patient with your patients. I think that's a good phrase to kind of think about when you're, especially in these areas where there's this high anxiety, and there's potentially a lot that folks have dealt with or had to get through to get to this point, to be sitting in front of you, the genetic counselor, at that point. You had mentioned that since it's not necessarily 100% yes or no, that sometimes you will offer the option or discuss the option, a prenatal diagnostic test. So one that's done after the embryo has been implanted, the patient is pregnant. So something like an amniocentesis, right? That can be done to maybe look at that same gene change or potentially a missing chromosome or something. It can look at a few different things. Do a lot of folks end up undergoing that type of diagnostic testing, or do you find that patients, like you said, it's holding their breath? So do they not want to take any chances, because we do know that amnio and CVS do have some percentage of risk?
I would say it's very personal with the patient. I would say for chromosome issues, it's nice because we have another screening test called NIPT and serum screening, which is available. So a lot of patients will opt to do that, which is great. And that's like another piece of reassurance that's not invasive. So I think that's a really great option. If you are an IVF patient, definitely look into doing something like NIPT or, serum screening, depending on where you are. I think those are great options. I will say, like you said, because there is a risk, it's not a large risk, but again, everyone's feeling of what large risk is different, because there is a risk for pregnancy loss with both CVS chorionic villus sampling and amniocentesis. I do see that there are a lot of our IVF patients that I've personally dealt with. Again, I'm sure there's different, but in my experience have declined invasive testing because they feel like they've gotten this far. There's no way they're risking it, and they want this baby by hook or by crook. Now, I've had patients that do. I think it all depends on what we're seeing. So I think an IVF patient that has no ultrasound findings and has had negative prenatal screening, so negative at, like I said, NIPT and negative serum screening, I would say in my experience is more likely to decline invasive testing. Now, if we have a patient who's had negative serum screening, negative NIPT, but we're seeing certain things on ultrasound and concerning findings, I think the conversation becomes different. And that's with any of my patients, whether they've done IVF or not. I think there is a more of a propensity to want to know, but not everyone. Some people are not interested. And that's the beauty of working in reproductive genetics. Everyone is going to feel differently.
Right. And it's their decision, right? You're going through them, giving them the information, and they're making that decision. You've mentioned a few things, but what would you say is one of the hardest parts about being in the reproductive genetic field?
To be honest, the hardest part of working in reproductive genetics is giving people very bad news. We deal with some very high highs, like I said, and very low lows. And telling people, that their child has potentially like a life-limiting illness is really hard, especially when they're pregnant and it's a desperately wanted pregnancy. That is really difficult. I have a lot of empathy for that. I'm a mom myself. I've been pregnant. I've been lucky enough to have been pregnant. I'm carrying my pregnancies. So that's very, very hard. I think that that's probably the hardest things that I've had conversations with and holding space for them. But I think the beauty of being a genetic counselor is that I'm able to give them good information and I'm able to support them in the best way I can. It's not my life. It's not my child. It's not my pregnancy, but I can be there for you, hopefully in a space that makes this something, I don't want to say manageable, but gives you tools to best get through this as best you can.
Right, right. What would you say then is kind of the most rewarding part of working in reproductive genetics?
Helping people have babies. I love that. I love helping build families and being part of that process. I think it's really special to be in that process, to be in that space, and especially like we said in the IVF space. These are people who really wanted pregnancies for a long, long time and wanting to be parents, and helping to be part of that process is really special because, like I shared with you before, I myself as a mom, but I'm an IVF mom. And so I've gotten that support from others, and to be able to give that support to patients is really great, and to be part of their journey as well.
Well, and that's wonderful that you're able to take that personal experience and, like you said, help others potentially going on that IVF journey and navigating those challenges. If our listeners walk away just remembering one thing from the conversation, because we've covered quite a bit, so if they remember one thing, what is it that you hope that they take away?
So for our patient listeners, meet with a genetic counselor. IVF is very, very nuanced. Whether you're doing PGT or not, meet with a genetic counselor. Make sure that you are getting the personalized service that you deserve. For our providers, same sort of thing. IVF is very, very nuanced. Make sure you're talking to a genetics provider. If you are a genetics provider, find someone in the reproductive space. Make sure that you're giving your patient the best information as possible. Just remember that, when you're dealing with someone here, you are hopefully leading them to all of their hopes and dreams. This may be a 45-minute consult for you, but this may mean everything to the patient, and keep that in mind. Hold that space and make sure that you are, as supportive as possible.
I appreciate it. And I appreciate you having something for both the patients and the providers. And that call out, like you said, it may be a 45-minute consult for a provider, but it's potentially their whole world at that appointment. Well, thank you so much, Natalie, for being on the podcast today. I really enjoyed talking with you and learning more about PGT.
Thank you so much for having me, Kate.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening, and join us next time.